Okay, so what we're doing now is, for those people in the Monday section, we were unable to get through the entire lecture on cardiac. We got through MI, but we did not get to cardiac heart failure. We did not get to congestive heart failure. So we will quickly go through these slides right now so that everybody has the same information going. So heart failure, so on Monday. As we just saw, we talked about, in the lecture, we talked about MI. So what happens if you have, let's say you have a massive MI, you survive it, yippee, and now what are you left with now that you have some scar tissue that has formed over your heart? What could possibly happen? Well, you could have it's going to leave a structural disorder of the heart, and what could happen is your problems just aren't over. Let's say you never have another heart attack again. You might be going into cardiac failure. In my personal experiences in pediatrics, I usually see heart failure happening in children who are actually born with cardiac abnormalities to their heart. So what we're usually seeing is a structure failure to the tissue, to the actual myocardium of the heart, and or possibly to the valves within the heart. So we will see that the heart will not pump the way it's supposed to. And remember the concept here: the heart is basically two pumps in one, the right side and the left side. So that is where we have to keep in mind when we are looking at where there's a failure on the left side or the right side, then where it will actually cause issues. So some of the common causes: coronary artery disease, otherwise CAD. So we can see coronary artery disease can lead to this. Reason being is coronary artery disease can lead to increased peripheral vascular resistance. So that means what the heart is pumping out to, it has to pump harder to pump blood through the tissues it's trying to perfuse. And what that can do is that can actually lead to problems with the heart itself. We can see that hypertension can lead to this as well. Again, the same sort of reason as the coronary artery disease. Increased peripheral vascular resistance then leading to changes within the myocardium of the heart. And we can see something called dilated cardiomyopathy, where there's a dilation happening within some of the vessels or in the heart itself, or actual diseases of the valves within the heart, where then the valves don't close completely, which means blood will flow back into one of the chambers of the heart. And hopefully I don't have to review all this with you. Please just take a look at this. Make sure that you understand how the heart works from left side to right side. This is from anatomy, and also what systole and diastole means as well. Now, when I'm studying for cardiac failure, I like to draw in cartoon form because, and do these sort of things. This is not mine. I got this from off of the internet. But what it actually shows you is you do not have to draw really, really good anatomical structures and diagrams and everything to have a good idea of how the heart actually works and when the function is not working. You can draw something as simple as a heart like this, okay? And then structurally draw in where the blood is coming from. We see the right side of the heart receives blood from the rest of the body. So we can see that you have to think about the blood gets received on the right side of the heart from the rest of the body. Now, what is actually happening here? When we're thinking of pathology, we have to remember this little functional part of anatomy. When the blood is coming from the rest of the body through the hepatic portal system and the venous system here, when it reaches this side of the heart, what's happening is the blood is under low pressure. That's why it's coming from veins. Okay, veins don't have the same musculature around it as blood coming out of the left side of the heart. So veins are actually carrying low pressure blood. What the right side of the blood has to do is it has to charge it up. It has to repressurize that blood so that it can send it through the pulmonary artery, and in this case it is under high pressure, even though it is blue blood and has not been oxygenated yet. It is under high pressure right now, going to where? Going to from the pulmonary artery to the lungs. And what is the lungs? Lungs is a huge capillary bed. So we see this over and over again with the right side and the left side of the heart. Blood is charged up and pressurized when it is about to go through a capillary bed, where it will then have an exchange of oxygen and carbon dioxide, specifically exchanging carbon dioxide for oxygen in the capillary bed of the lungs. And when it comes out of the lungs and comes into this side over here, it comes through the pulmonary vein, and because it has gone through the lungs, through that capillary bed, and as we see it comes in even from the lungs, we see it comes through a pulmonary vein. It's oxygenated now, but because it has gone through the capillary bed of the lungs, it is under low pressure right now, and we have to recharge it back up and send it out to the rest of the body. And when it comes out of the aorta, it's now charged up as well. It's been pressurized again. So we see this constant job that the heart has to do. One side of the heart takes blood that is under low pressure, repressurizes it, and sends it out to a capillary bed. Same thing on the right side. It's collecting blood from the entire body, recharging it, sending it to the capillary bed, which is the lungs. So if you remember that, then all you have to do, as we're looking at heart failure, is figure out which side is failing, and then look at this as though where is the charged blood going, and if it can't do that, what would happen? And look also to where it's receiving blood, because if there's an issue with the left side of the heart, and the left side of the heart can't pump out as well as it should, what's happening to all this blood coming in from the pulmonary vein, from the lungs? There's going to be a backup on the left side. Likewise, on the right side, if the right side starts to fail, it can't charge the blood going out to the lungs, but in particular, it cannot do anything with the blood it is receiving from the rest of the body, so there's going to be a backup. It's like if you screw this up here on the right side of the heart, there's a dam within it, and the water can't flow through, it's going to back up behind the dam. Same with the left side of the heart here. If you screw up the left side of the heart, you're putting a dam in this flow of blood, and it's going to back up over here. Okay, so let's keep that in mind as we're going forward. Cardiac output, you always have to remember, is going to be this little formula right here. Cardiac output is stroke volume times heart rate. So we always want to keep the cardiac output the same to perfuse, and if we don't, then we have to increase one or the other. The efficiency of the heart is determined by the blood that it injects, and what we are trying to do is it's regulated by the balance also between, we see that we can change this based by the central nervous system, the sympathetic nervous system and the peripheral nervous system. Persons with heart failure use what they also call their cardiac reserve. And what your cardiac reserve is right now, as you're sitting here listening to this lecture, your heart could do more, okay? If I tell you as you're sitting at this lecture, stand up and start jogging on the spot, obviously there is an increased demand for blood for your muscles, okay, because they're doing work. So your heart can actually start beating harder, it can start beating faster, to meet that need of you jogging on the spot. So what we see is that your body has a cardiac reserve. Okay, the cardiac reserve. So your heart has the extra ability to actually then do extra work to meet up for the extra needs that it needs. In cardiac failure, what's happening here is that the damaged heart will actually have to speed up because it's not pumping. It doesn't have enough stroke volume going out. It will try and beat faster. And when it's beating faster like this, it's increasing it's basically using up its reserve. A healthy heart like yours right now, sitting there, and then if you stand up and start running on the spot, it will beat faster. It's using up some of its reserve capacity to meet the needs that are happening, meet the needs that are occurring because you're jogging on the spot. But if you are, unfortunately, if your heart is damaged, then it will start to beat harder, and in doing so, it is using up that reserve capacity it has to beat harder and beat faster because it's damaged. It still has to meet the cardiac output. But usually what we'll see in a lot of times when we have damage to the heart, there's damage to the myocardium, which means that it can't have a large stroke volume as it did before. It cannot contract as hard. It cannot actually contract and give out as much blood. So what does it do? It starts to beat harder. So there's usually an increased heart rate. And once you start jacking up the heart rate to meet this, then you are basically dwindling your reserves. If your heart is already beating at 110 beats a minute normally, just sitting there, then you do not have much room or much reserve should the need arise for even increased metabolic needs. So that's why we say the cardiac reserve for persons at rest who have cardiac failure are actually increased. Okay, and then you actually do not have much. And we usually say when these people come in and with problems, say for example they've got pneumonia or a massive infection going on, we usually say they do not have as much cardiac reserves, so they're more fragile. Remember the heart is a pump as well that I've already spoken about. You need to remember what these ones are: preload, afterload, and contractility. These things, please just read over them on their slide here, and these are part of your anatomy that you should be well aware of. And just to help you along with the preload and afterload as well, here are some nice little diagrams as well that you can use, taking these off the internet. They're very ubiquitous on the internet to talk to about preload and afterload and how they work as well. The types of heart failure that we're going to be concerned about for our testing purposes is high output versus low output failure. So is the cardiac output too high or too low? And we see that with systolic or diastolic failure, the heart is failing to pump enough blood, okay, or failing to accept enough blood through the body or the lungs, and then that's going to translate down to, is it right-sided or left-sided heart failure? If we have problems with systolic function, which means how hard the heart can push, we see a decrease in myocardial contractility. So that means the ejection factor, or how much the blood can actually produce, or how much fraction of the blood is pumped out, tends to decrease. And we then see with systolic dysfunction a decreased ejection factor of almost 40%. So your heart works less than 40%. It doesn't have the strength within its ventricles to eject out that blood. And what we will end up seeing with systolic dysfunction is we end up seeing end diastolic and end diastolic volumes lead to what we call increased preload. So we can't get the blood out, but the amount of blood that ends up coming into the atrium ends up building and ends up backing up. And what ends up happening is if it backs up, then you're going to get too much of the blood in there, and you end up getting sometimes it overstretches, but the blood cannot actually then eject it out as well. But we see that blood also will accumulate in the atrium, as I just said, and the pulmonary veins, and that leads to pulmonary congestion. So if the blood, so this is usually is what we call left-sided heart failure, is where we will see this. In diastolic dysfunction, it's the inability for the ventricle to fill sufficiently during diastole, and what ends up happening is this impedes the expansion, leads to increased intraventricular pressure and urine volume, leads to increased pressure in the left atrium, pulmonary congestion and decreased lung compliance occur, and then cardiac output is decreased because of the decreased filling. Now, excuse me. For testing purposes, what we really need to know is how to describe, and what you really need to be familiar with is left-sided and right-sided heart failure, how those two occur, and the symptomatology that goes along with it. I'll be asking more questions in more detail about left-sided and right-sided than I would about specifically diastolic and systolic dysfunction. Okay, in reality, there might only want to be one or two questions on diastolic dysfunction and systolic dysfunction. More in particular, we will not need to know how those are quantified when we talk about left versus right-sided heart failure. So left-sided heart failure, we see decreased cardiac output with decreased peripheral, and this should be BP, okay, and progressive accumulation of blood, decreased peripheral blood flow, that's what BF stands for, blood flow. And we will say progressive accumulation of blood within the pulmonary circulation. So the left ventricle isn't pumping the blood out. That's where the dam is, and therefore blood, and then remember the right side is doing fine right now. The right side is pumping all the blood it can at the way it should through the lungs. It's oxygenating, and it's trying to then make its way through that same amount of volume, wants to then be pushed through the left side of the heart, but it can't. It's like the right side of the heart is pumping out 2 liters of blood at any particular time, but the left side can only accept 1 liter. Where is that extra liter going to go? Well, it doesn't go anywhere. It backs up in the pulmonary circulation. So the pulmonary veins, it'll back up in the pulmonary veins, backs up in the lungs as well. And what this leads to then is pulmonary congestion in the lungs, because the fluid has to go somewhere. So what will happen is albumin and plasma will seep out of the blood that is backing up in the lungs, and it will actually seep into the alveoli, into that free airspace, because that's at a lower resistance. So we will see a decreased injection fraction into the systemic circulation. We see increased left ventricular and left atrial pressures. We see pulmonary edema because the blood is backing up into the lungs. So what will happen is components of the blood will seep into the lungs. And this is usually caused by hypertension, an acute MI where you actually have damage to the myocardium of the left side of the heart, and valve defects on the left side of the heart. So that's where you're going to see the dam and then the backup happen, okay, in the lungs with left-sided. And when you back up in the lungs, you will get pulmonary congestion, okay? And pulmonary congestion basically means fluid seeping into a certain area, okay? Just like you have nasal congestion. How do you have nasal congestion? Well, blood flow increases to the mucous membranes in your nose, and you've got a lot of blood in those mucous membranes, and then what ends up happening is blood has to go somewhere, or the volume has to go somewhere. You start draining fluid into your mucous membranes, okay? Same sort of thing happens in the heart. If you increase too much blood in the lungs, it's got to go somewhere. The excess fluid has to go somewhere. It seeps into the alveoli, into that airspace of the lungs, okay? Right side, it's a little bit different, okay? We've got, if right side fails, then it can't accept the blood that's coming from the rest of the periphery of the body. So what ends up, and it can't actually eject it out to the lungs. What do we see end up happening? Well, we see minimal pulmonary congestion because we're not backing up into the lungs. We're backing up everywhere else in the periphery and in the abdomen. So this is, we see engorgement of the systemic and the hepatic system. So we will see 2 major things there. If the hepatic system is engorged and starts to fill up, then we will see congestion of the viscera, or basically we'll see ascites in your abdominal cavity. We'll see engorgement of the abdominal cavity. We'll see engorgement of the liver. We will see, and we'll also see edema to the lower extremities. So we usually say that if you look at it here, you see that the failure of the right ventricle leads to increased right ventricular end diastolic volume. So this is where that term systolic and diastolic comes from. Okay, with the right side of the heart, we usually see problems with the end diastolic volume, and that means a backup or a dam up of the ability to receive the blood from the rest of the body, and in particular, abdomen and periphery, specifically feet, is when where you're going to see engorgement happen, and you're going to see edema and swelling happen in those areas. And this is what left-sided heart failure looks like. Look. With left-sided, we have 2 diagrams there. We're going to have one for left-sided and right-sided. What is this guy doing? And I mentioned it to the one class, the Thursday class, but look at it for the Wednesday class. Look at what sort of position is he sitting in. He's sitting in a tripod position. Why? Because his lungs are filled up with fluid. Look what can occur from this. We see dyspnea, pain on exertion. We see elevated pulmonary cardiac wedge. I'm not too worried about that when we go forward into testing purposes, but this is what I am worried about down here. The symptoms of pulmonary congestion: cough, crackles, wheezes, blood-tinged sputum, and tachypnea. Why do we get this blood-tinged sputum? Well, if we're looking at the alveoli, what's going to end up happening is that not only are you going to get fluid seeping across into the alveoli, but what ends up happening is you can sometimes get blood coming along with it. Albumin and blood start to seep over with that fluid, and then the sputum ends up being tinged. With that, when you have all that, what you end up seeing is restlessness, confusion. Why? Because you're not pumping up blood to your brain. we see orthopnea, okay, we see tachycardia, we see exertional dyspnea, so every time that you do any sort of exertion going upstairs, for example, you will get pain upon inspiration. We will see fatigue, and we will see cyanosis. So this means that your periphery will turn blue. Cyanosis, around his lips right now, you see bluing around his lips. That's not just drawn poorly, that's drawn because for a specific reason. This means cyanosis, this means bluing around the lips, bluing around the fingers, okay, bluing around the feet. It means that this area cannot get enough oxygenated blood because the left side of the heart can't pump it out. With the right-sided heart failure, look, she's sitting up properly, but what's very evident in here, we see big swollen feet, dependent edema. We see a big tummy. It doesn't mean that she's fat. It means it's engorged with blood. With this as well, we will see, and they call this with right-sided heart failure, we see this thing, and they call it cor pulmonale, which means fatigue, increased venous pressure, ascites, which ascites is basically edema accumulating around the abdominal cavity, okay? And we see an enlarged liver and spleen, very different than what we talked about just a second ago when we talked about left-sided heart failure. It can be secondary due to some chronic pulmonary issues. We will see distended jugular veins. We will see complaints of GI and GI distress. That makes sense if this is all engaged or engorged. We will see weight gain. That weight gain is primarily fluid accumulation. And we will see dependent edema. So dependent meaning depends on the position you're in. As this person sits up, it's harder to move fluid against gravity, therefore she will end up getting edema in her feet. If she lays down and lays flat, then we will see the edema start to decrease from her feet. So that's what dependent edema is. It's dependent on the position you're in, usually an upright position where your heart has to work against gravity. And then I like this diagram, I've given it to you guys. You can play with it. Talk about left-sided heart failure. If the left side fails, then where does it back up? Backs up over here. Then that means you're going to, if you get left-sided heart failure, left-sided heart failure means that you are not accepting blood from this side. This side is failing. So failing to accept the blood from where? Failing to accept blood from the heart. So we screw up the left side of the heart, back up along here. Where are you going to see the backup occurring? Here in the lungs. Okay? All the things we talked about with regards to pulmonary congestion. If we look at the right side failing, where does it back up? Well, the right side collects all its blood from where? Collects it from the body. So where's the backup going to happen? Here. Okay? So this is where the core of the symptoms happen here. All right? So use this, play with that, put the symptoms in there, and you can use it, and it's very easy. All you have to do is just draw a pair of lungs over here, a heart, and then the rest of the body over here. And the way I did that when I was going through university is I drew this. I just drew all the things, and I drew this as an exploded homunculus, and then I would say, screw up the left side of the heart. What's the left side accepting from? Here. And then I would draw little waves in here saying I'm getting pulmonary congestion. And then I would draw it as if if the right side failed. Where does the right collect all the blood from? From here. Okay, where does it screw up from? I'm going to get all this little edema and crap happening here. And use it with it, play with it, draw it out so that you actually get an idea. And you can figure out how the dysfunction occurs when you screw up with one side of the heart or the other. And for those of you who need to see this broken down even more so, all these slides are doing is just use whatever slide works in your head to give you an idea. You'll see that if we look at right-sided or left-sided heart failure, all the stuff we just talked about is listed here, but it's listed in this format. So I'm giving you these slides in a number of different ways. Use what works for you, for yourself to study and understand, and test yourself, okay? If you need to, put stuff down, okay, and then say left-sided heart failure. What occurs? Write it all out really quickly, okay, and then go to this slide or go to whatever your notes are and say, did I get everything right? No, I got it wrong. Go back and do it again. Okay, you'll probably find doing it about 3 or 4 times over the course of maybe 15 minutes of a half an hour, then you'll get it down. Then 3 or 4 hours later, when you're sitting in the bathroom, don't look on your phone. looking over my notes, okay, take a piece of paper, scribble out left side and right-sided heart failure, okay, while you're having a poo, okay, just don't push too hard and pass out. But do that, do it quickly, scribble it out really quickly, it doesn't have to be that legible, just legible for you, and see if you remembered it correctly, okay. This is how you'll remember things going forward for your tests. And then if you really didn't like that previous diagram, then here's a really simplified one as well that has all the same information that was on the previous slide and the previous slide before that, but it just shows the heart as two balls. Okay, so it just shows to show you that it's a very easy way to do it. So use whichever one works for you. And then some of the compensator mechanisms that we have to consider as well is we have to consider how the body will try and compensate or fix this sort of thing. We have this thing called Frank-Starling mechanism. We have the sympathetic nervous system will be worked. The renin-angiotensin aldosterone mechanism may work to try and to fix these things as well. And this is more of a long-term sort of thing that the body tries to do. Naturistic peptides, some endothelials may work as well, and sometimes, which is not necessarily a good thing, myocardial hypertrophy and remodeling. So what this is meaning is the heart muscle actually starts to get enlarged. But as I can't do it on this in front of you right now, and on this, but if your heart muscle starts to increase in size, remember your heart muscle is a wall. It will thicken to the outside of the heart, and plus it will thicken inside, in towards the ventricle. So what that means is you end up getting, when the heart muscle hypertrophies or gets larger, it will decrease the space within the ventricle, because the heart muscle not only grows outwards, but it also grows inwards towards the ventricle. And if it grows inwards, it's like the walls closing in on you. If you're in your house right now, or whatever room you're in, I want you to thicken the walls of the room that you're in right now. It's going to get thicker going out towards the outside of that room, but it's also going to thicken evenly to the inside of your room, and keep doing that. The space within the room of the room that you're in right now will get smaller. That's the stroke volume has now decreased. So now your body has to pick up and actually pump harder because it can't have as much volume to put out. So myocardial hypertrophy and remodeling is not a good thing. Okay, even though the heart compensates for it, it actually ends up making heart failure worse in the long run. The Frank-Starling mechanism is very simple. It is, the end result is that we want to increase the stroke volume. How do we do that? Well, you can do one of two things. You can actually, as the preload increases, then the heart stretches more, which means it'll try and pump harder. This allows you to get increased stroke volume at a lower heart rate. And this is one of the mechanisms your heart tries to do, but all that extra stretch that it's doing, unfortunately, will lead towards hypertrophy later on. So we see with Frank-Starling's mechanism where we actually have more stretch going on in the heart tries to contract harder. Unfortunately, on the previous slide, we see that a long-term stretch like this will lead to, unfortunately, cardiac hypertrophy. And some manifestations of heart failure, what we will see are three general concepts that we will see in the failing heart. We will see effects of impaired pumping. We will see effects of decreased renal blood flow. So this unfortunately means that if you cannot actually pump to your kidneys as well, then that means you're going to have fluid accumulation. And we'll see effects on the sympathetic nervous system as well. As we sort of said with heart failure, fluid retention and edema occurs, respiratory manifestations, dyspnea, pain upon breathing, just at rest, or exertional pain upon breathing, fatigue and weakness, mental confusion, cachexia and malnutrition, so it's sort of a wasting sort of a situation happening. We will see cyanosis happening more so in left-sided heart failure. We will even see arrhythmias occurring as well, and unfortunately even sudden cardiac death. Acute pulmonary edema, we're going to talk a little bit more about this actually in respiratory. For purposes of cardiac failure, I want you to know which cardiac failure it occurs in and what are the symptoms that you will see. So I will expect you to know for test number 2 that they actually have blood-tinged sputum. The mechanism of blood-tinged sputum, I will expect you to know a little bit more on the next test when we talk about pulmonary edema and why that occurs in more detail. But in particularly, we want to know that pulmonary edema occurs with left-sided heart failure. It is life-threatening. It will lead to decreased O2 to the brain, leads to confusion, dyspnea and air hunger, frothy blood sputum, and crackles. This is what you have to know for left-sided cardiac failure when it comes to pulmonary edema. Okay? Specifically why you get pulmonary edema and it's blood-tinged and everything like that, we will talk more about when we talk about pulmonary edema in respiratory. Diagnostics that you'll do for left-sided or right-sided heart failure, physical exam, okay? Know which one, know left-sided or right-sided, which one is going to have the vein distension, okay? Which one's going to have the more likely to have edema to the extremities? Which one is you going to have the nasty breath sounds for? Which ones are you going to need to have pulse oximetry for? Which one do you have? Which one has the cyanosis occurring? That's important to differentiate between which one for the next test, for test number 2. You can do some laboratory results as well. You can do some CBC, electrolytes. The big thing we do is we do some echocardiography, and basically this is using an ultrasound to actually look at the function of the heart, and you can actually see in enlargement of the heart. They can actually measure ejection fractures and all these sort of things with ultrasound. It's become quite the thing to do right now, is to using echocardiography. And as I said, echocardiography is just simply ultrasound specifically for cardiac function. In an acute emergency, there's measurement of the central venous pressure, and sometimes they will even put in catheters to actually measure output of the heart and actually control the heart and actually dump medications directly onto the cardiac muscle. Treatment, well, unfortunately, if you have cardiac failure, what you do is you need a new heart. But what usually happens, because it's usually happening in the aged people who are an older population, we try and fix it with exercise, sodium and fluid restriction, weight management, and then some drugs that we will talk about in pharmacology. Just remember the types of drug classifications, which are diuretics, digoxin, which we just talked about in pharmacology. So diuretics, digoxin, otherwise that one would be a cardiac glycoside drug. And we will see 2 blood pressure medications, ACE inhibitors and beta blockers, which we will talk about very shortly in pharmacology. So some blood pressure medications, cardiac glycosides, and diuretics, those are the 3 that will be used in pharmacological management when we're talking about treating it. Oxygen therapy, specifically if you have left-sided heart failure and you're cyanotic, oxygen therapy is something we will see a lot of these patients will be used. They try cardiac resynchronization and some implants to try and improve the output of the heart as well, and some mechanical support, some ventricular assisted devices either internally or externally to try and help with cardiac failure.